were to consider the concept of a road to Nirvana in the practice of oncology, what does that look like? And how do we actually build the highway to get there? Our guest today has some answers to that. Today, I'm joined by Dr. Debra Patt, one of the most impressive physicians that I've ever met. She's a practicing breast oncologist, an executive vice president at Texas Oncology, the president of the Community Oncology Alliance, and serves on the ASCO Board of Directors, where she chairs the AI task force. There are really very few people in the world that get to see the full picture, the intersection of policy, technology, and care delivery like she does. In this episode, we'll talk about what Nirvana really means in cancer care and what it really takes to pave the road for it. We explore how digital tools are helping clinicians be more present with patients, how Texas Oncology scaled one of the largest AI implementations in the field, and what made it truly stick with clinicians. We also talk about how we already have the, quote, Ferraris of healthcare innovation. But to reach that Nirvana, we need to build the highways of policy alignment, infrastructure, and workflow that let those technologies actually drive impact. If you care about building the future of oncology from the clinic outward, this conversation reveals what real progress will take. Let's go. So today we have a really exciting guest. We have Dr. Debra Patt with us today. Dr. Patt, thank you so much for joining us.
Thanks for having me, Matt.
I know we have a lot to talk about, but I'd like to just start with kind of your story. Can you just kind of share a little bit with our audience about kind of your path to oncology and kind of what drew you to focus on breast cancer and kind of how you got to, where you are today?
Sure. So I'm a breast medical oncologist. I've been practicing as a partner in Texas Oncology for just about 20 years. I started training in internal medicine and pediatrics and realized very quickly that I really wanted to go into a field that was really complicated and dealt with the whole body, not just one organ system, that was ripe for innovation and that had a lot of potential for change over time. And so I became really interested in cancer and decided to isolate my practice to breast cancer patients because seeing women through this journey, mostly, it's really gratifying. And so I really enjoyed doing that. And I think for many of us as oncologists, we're problem solvers and optimists by nature. And so doing more problem solving is what led me to things like health services research. So thinking about clinical care delivery, thinking about public policy. So I'm a leader for public policy for US Oncology and for Texas Oncology, and thinking about administration, the administrative aspects of care delivery, because we want to be great oncologists and we don't want stuff to get in our way, which is so pertinent to our discussion. We want things to help us be oncologists and be efficient and effective. So that's sort of how I ventured into leadership. And I now serve as an executive vice president of Texas Oncology, where I'm the managing medical director over our Central Texas, Gulf, and Rio Grande Valley regions. And I serve as the president of the Community Oncology Alliance, which is a professional society that serves private, independently owned community oncology practices and tries to help us execute on our mission. So I find that very gratifying. And I would say if you sort of think of my career in buckets, I'm a breast cancer doctor. I'm a clinical informatics specialist. I actually have a board certification in clinical informatics and do a lot of our digital healthcare work. I do a lot of public policy and then business strategy.
I appreciate you for sharing that. And Dr. Patt, you're probably one of the most impressive people I've ever met in my life. So thank you again for joining us in this conversation. I think you have a really interesting vantage point, not only being a practicing oncologist, but also sitting and being involved on a lot of the policy side and also the technology side as well. And, I'm excited for, all the different topics that we're getting into today. But I guess just before we kind of dive into all of that, I kind of wanted to just start with, the human side, right? And, really the doctor-patient connection, because I think, that's where in our previous conversations, we spent a lot of time talking about, and that's really kind of, where everything kind of starts. We're all working in the service for the patients. Can you just start by kind of sharing us, what your personal kind of approach to care is and, how that philosophy has kind of shaped, the work and your perspective on, how you approach care?
I've been doing this a long time, for 20 years now. So my ability to understand how to treat someone's breast cancer is right at my fingertips, and it has been for a long time because I've had a lot of education and a lot of experience. And so that's the easy part. I think the hard part sometimes is getting patients through that journey, making sure that they're educated appropriately, making sure they understand how to put cancer in the context of the rest of their life. Because, while we've seen innovative therapies evolve, and that's completely amazing, we don't just want to make cancer not be the ultimate journey for patients, right? Because we want to control their cancer, but we want for cancer therapy to not disrupt their lives. And so I spend a lot of time trying to help patients navigate that journey, providing them education, trying to provide a personal experience for them. And that's why me operating at the top of my license is really critical, because I want my interaction with patients to make them feel better, to make them understand how they're going to live their life. I don't want them to see the back of my head because I'm typing on the computer. I don't want them to see the back of my head because I'm typing in orders. I want to be present with them. And I want to be able to, touch them when they cry and hand them a tissue and walk them through education. And I think that helps patients live much better through their cancer journey. It never ceases to amaze me, Matt, how different people can be affected by cancer variably. I have patients that have pre-invasive breast cancer, DCIS, that will likely never contribute to their morbidity or mortality, and it can plague them. And other patients that have metastatic advanced cancer that live their lives very normally. And I attribute, to some of that, there's some difference just in patients, but we can help a lot with that if we can really be present for patients and educate them. Knowledge is power. And so if we can be better educators and help patients navigate their journey better, then I think we've done a real service to executing on this mission of great cancer care in our communities.
It's such a critical point because one of the things that I've experienced personally, even with my mom, is that yes, there's a science and we want the best science. Yes, there's a component of like healthcare where you have to administer the care. But at the end of the day, it all comes down to, is that patient receiving kind of care in the way that they would kind of be cared for by their family members, be cared for by, somebody that truly cares about them, beyond just the science and the administration. And so, I think technology is really at an interesting kind of turning point where, we can really start to see how technology can really begin to kind of humanize the patient physician interaction. And I know, throughout your career, you've seen just a massive evolution from technology, even starting from paper charts and, now working with, predictive models and figuring out how to, the policy around it, looking back, to your first year in clinic, is there anything that like you believed about, caring for patients that you completely got wrong or you challenge today and say, oh my gosh, like I can't believe like we're kind of in this moment?
I thought change would happen faster,
Mhm.
specifically how we deliver care to patients. I thought that would happen faster than it has. And I will tell you, Matt, the challenges in how we change, I think, are different than I had anticipated when I started. And we've talked about this before, but I often talk about sort of the road to digitally enabled better healthcare as sort of like the road to Nirvana. Nirvana being this place of perfect healthcare in the future where doctors and nurses act at top of license and patients are able to not wait and really spend minimal time in their care journey so they can be focused on their lives and this future state. I thought the hard, tough choices would be the various vendors that we work with along that journey on the road to Nirvana. And what I appreciate over time is that we probably will travel to far fewer places in a short order because many of our partners, Matt, like in DeepScribe, it's been the case for sure. You develop incremental functionality to meet us where we are, and so we're not using multiple different vendors to meet different needs, but we're going further with each individual vendor. So that's one piece. Another piece is I thought the hard part was figuring out who you work with, and not to say that that's easy because it's really important and it's hard. But the hardest part is actually the implementation and change management, because to change the behavior, especially of clinicians, to change the process workflow of clinicians and administrators is a very heavy lift. And that's true, I think, for any digital healthcare solution that you lift. If people have to change their own process, then that becomes a challenge for them. And it's not to say that it's undoable, but you just need to think about that because it's a heavier lift than you'll anticipate.
Yeah, I mean, I think it's crazy. Like as an outsider, building a technology company in healthcare, that has been the constant challenge, right? Like you would think that you create something that is so obvious, but really the change management and getting people to trust the product or getting people to trust the technology is such a crucial part that I think is often overlooked from outsiders, trying to drive adoption in healthcare. I think Texas Oncology, has been doing, really leading the way in implementing technology and doing great things, especially in AI. I mean, even with, DeepScribe, when we first started implementing, I think it was probably the largest implementation of AI in oncology. And, I'd love if you can kind of walk through, how that experience was. And if you can kind of share with the audience, like, what are some of the key learnings on the best ways to kind of implement AI, quickly, but responsibly at the same time?
I think there's a lot of planning that needs to go in ahead of time to try to understand your process, your integration, security, compliance, legal ramifications, all of those things. Once that pre-work is done, though, I think there are a few key pearls that were really tenets of our success in implementation. One was having physician champions. So Dr. Scott Cheek and Guri Doshi were physician champions that were great. They understood the platform really well, understood how it would work within the clinical workflow, and that it would be minimally disruptive. And then the second was you have to have an implementation champion. And I think people wouldn't believe it, but in Texas Oncology, where we have 300 sites of service and, over 600 doctors and over 300 advanced practice providers, we had one person championing the implementation of DeepScribe throughout Texas Oncology, James Lindsay, who is a wonderful leader in the technology space for our organization. And he sort of went through different sites. And I think this was a pearl. He wanted to socialize the platform to everyone, but he picked key leaders, sort of key opinion leaders, if you will, people to sort of drive the change in different locations that they could see how it works. And then those people could be resources to the other people that then onboarded. And of course, DeepScribe was great too. And I think this is a critical point that, as we are all on the journey of the road to Nirvana, and we will have many digital healthcare transformations, whether it's incremental functionality of our portal and pushing out education or using AI for chart summarization or clinical trial eligibility or triage or whatever it is. We really need to have vendors that partner with us on solutions because from an operational standpoint, we just can't do everything by ourselves in an organization. Because in a practice like in Texas Oncology, we're a large organization. It's just such a heavy lift. We're not a ship that turns on a dime. And in smaller organizations, there's a lot of variability in the operational teams that are supporting some of those functions. And so having good partnership with vendors that are coming to you with how to implement easily, that's where we've seen real success. And that's certainly been true with DeepScribe and also with other vendors that we've worked with.
Everything that you said was spot on. Like, I think we wouldn't have been able to do it without the champions that you've named. I think really the momentum that was created was kind of akin to like this cult-like following of, hey, this is not something that's just cool and like it's like kind of a one-trick pony that we can kind of play with. This is really kind of like a organizational wide strategic movement that we all want to kind of be a party to. And I think without that kind of culture and without that kind of sentiment around trying to adopt AI, you kind of are met with some almost like insurmountable obstacles along the way. And so, yeah, like you can have really good tech, right? You can have some people that really like it. But ultimately it's the partnership that really matters. And yeah, I mean, I couldn't thank, you guys enough for, really helping, pave that way for us at Texas Oncology.
Well, we appreciate the partnership. If it weren't for the responsiveness of your team and availability, we wouldn't have been able to implement either. When I went live, I needed to reach out to Chinmay, who's on your team, for assistance. And, your team being readily available. Again, you have to partner with vendors and you have to depend upon the vendors as you think about implementation. And we've seen that in many of the digital healthcare solutions that we've deployed.
Our product was far from perfect on the onset of the implementation. And really, I think, a key part of the partnership is being able to have these rapid iteration cycles where you're able to get real feedback from real users and then have the infrastructure to be able to absorb that feedback, change the product, and meet the physicians where they are. And, luckily, that's something that we've been able to do really well. It's also changed kind of our philosophy on how we build products, right? I think with AI, a lot of people have these debates around pre-training versus post-training. And, for us, what we really see power in is like being able to have this like level of adaptation at the inference level to allow the physicians to create almost their own models when using our product. It's rather than just building an ambient scribe, rather than just building an oncology specific model, we're really building kind of like a multi-layered kind of approach where you build a best-in-class ambient scribe, you build a best-in-class oncology model, but then you also build a best-in-class like Dr. Patt model, right? And we can't do that without the meaningful partnership with the users to give us the feedback that's required to actually to do it.
Yeah.
On the topic of adoption, right? Like I know one of the things that we talk about is like how do you drive further adoption from the onset? And one of the things that we talked about in kind of previous conversations is you kind of can see like meaningful use as one of the tools that maybe policy has placed in trying to drive the adoption of technology. And with it came interesting carrots and interesting sticks. How do you see kind of like the policy landscape kind of shaping out with kind of the diffusion of technology?
I think like with the onboarding of electronic health records, what we saw first was it was incentivized, which encouraged people to be early adopters, pioneers, settlers, and then later there were penalties. And so I think that did help to facilitate adoption to electronic health record use, other meaningful use. And so I think that that's where we're going. I think that those policy pivots have been meaningful. And I think that you do need incentives. You do need carrots and sticks in order to move the needle, to make sure that you put patients over paperwork. Because I was 30 when I became an oncologist, right? You're in school for a really long time. There are no super young oncologists out there, right? Because like it takes you a long time to do this. And so, I have partners that are in their 70s and 80s. And I will say, as I think about that, some of them are actually very technically innovative. But you can imagine that some people may be reluctant to change. And it can be hard to change, especially if you've been doing it the same way for 40 years. And so I think having carrots and sticks and ways to sort of help organizations change becomes really important.
Yeah, I think the carrots and sticks analogy is interesting. I think, ultimately the widespread adoption of electronic health records was good because, it allowed us kind of to have this new understanding of, care and how we administer care. But at the same time, it came with a lot of criticism. A lot of kind of vendors almost build products to check boxes and to meet attestations rather than to really build products for the clinicians. And I think we're at an interesting moment in AI to not make those same mistakes. I think there's a lot of really interesting work going around with CHI and the Joint Commission releasing kind of best practices to AI adoption. I'm curious to get kind of your take on these policies that are being pushed and how that might impact not only the adoption of AI but how the build of AI kind of emerges.
I think it's really important. And I'm really grateful for the work between CHI and the Joint Commission, because I think that we do need parsimonious policies that influence AI. I think one of the challenges that we have and many practices have is where, there's federal policy And, CHI and the Joint Commission is sort of signaling, right? It's signaling to where federal policy is going, because that's sort of how that works. Is they'll signal, federal policy will emerge based on that. But what we're seeing that I think is more challenging is that many states are developing policies that influence how we use digital tools in healthcare delivery, and they can be variable. And it's hard for vendors like you that have different states that you might work in. And what do you do to manage that? And then when you have people that manage your liability, right, they can give you counsel, but do they give you counsel that's pertinent to your state? Are they giving broad statements around it? I think it's challenging, and that's why I said at the very beginning, bringing in legal and compliance is really critical. But I think what's clear to me, and I think clear to you, is that, and probably to anyone that would listen to this podcast, is AI and digital tools will be everywhere all at once. And whether it's answering the phone, or how you are archiving the patient journey through dictation, or how you are managing your chart summarization and clinical trial eligibility, how you're coding and billing, how you're submitting prior authorization requests or managing the revenue cycle, it is going to be in every aspect of delivery. And so that conveys an obligation for us based on what we see signaled in the policies, and in Texas, where I practice, and some specific policies that were passed this legislative session around disclosure and heightening awareness. And I will say, I think it's important that organizations think about this carefully, because if you just say, hey, we're using artificial intelligence, that can sound kind of scary, especially to 70 or 80-year-old cancer patients that maybe don't really understand what that means. And so I really think of it as your practice or your organization is making investments in providing digital healthcare tools for you as a patient to try to navigate your journey more easily. Because the truth is, if you ask a patient, do you want AI to help in your healthcare? They might say, no, I don't want AI making your decisions. And AI should never be making decisions, because doctor-patient relationships are sanctified, and those are doctor-patient choices. But AI is going to help in a lot of ways. And so they might not understand that. But if you ask the same patient, do you want to look at Dr. Patt's hair from the back of her head because she's in front of her computer the whole time you're in the room with her? Would you prefer for her to look at you eye to eye and really interact with you in a more meaningful way? I think that's a no-brainer. They want to see your face. They want to get their prior authorization approved earlier. They want to have access to clinical trials if they're available. And so people need to clearly understand, I think, the risk and the benefit. And so I think when you look at organizations like the Joint Commission and CHI's advice, or organizations like ASCO, so I chaired ASCO's AI task force this last year, and we published some tenets of responsible use that I think are really important. Or you look at other professional society organizations, I think we're all trying to get at the same thing, to try to make sure that the people that are using these tools and the people for whom these tools are used for, that there's really clear understanding of the benefits and risks. There's transparency in the process. We do what we can to mitigate the hazards that are out there, and that's likely to evolve over time. And so I think I'm excited to see that. What I would like to see evolve that is not yet there is I would like to see parsimony federally in the policy, because I think it can be really problematic when there's state policies that vary for vendors that act across multiple different states.
Yeah, I completely agree with you. I mean, I think that the tension always between, technology innovation and regulation is really about, is perfect the enemy of the good, in my opinion. And, I agree that there needs to be really important guardrails and guidance from organizations that are really thinking, thoughtfully about this problem, to provide guidance to the industry about how they should deploy AI responsibly. If that is done state by state, that is almost the biggest detriment to innovation, because vendors like us are going to need to figure out how to comply with 50 different types of rules, rather than being able to focus on building products that actually deliver value for clinicians. Yeah, I completely agree. And, I think the interesting thing is that the state of the technology today, you start to see a lot of these green shoots where AI enabled care or AI assisted care is, a higher quality or a higher experience than the care without the AI assistance or, non AI assistance. And as the technology improves, I think these green shoots will really start to sprout into, standards of care, right? And it's not really about like, do you want to use AI or do you not want to use AI? It's really about, hey, like, do you want the best care, right?
Yeah.
And figuring out what the road to that is now is so important because the pace of innovation is something like we've never seen before. And
Right,
I think that
exactly.
moment is coming sooner than later. I'd love to kind of get your take. I know you're able to see a lot of different technologies and see how they're impacting care delivery today. What are some of the real world impacts that you're seeing, or are there examples that you can kind of point to where, hey, like a doctor using AI today is better than care that he or she would have provided without using it?
I think it does make us better in meaningful ways. And I'll talk about two that have happened to me in the last month because I think they're great examples. So clinical decision support should act to nudge care delivery choices between doctors and patients. But at the end of the day, those are choices between doctors and patients. As a breast cancer specialist, again, as I've already said, I've done this for 20 years. I usually know within 30 seconds of walking in a room what I need to do to treat someone's breast cancer, whether they're new to me or have new progression. Like in my life, that is an easy decision.
Mm-hmm.
But what is a difficult decision is the many other things that interact with a human to make care delivery complicated. So I'll give you two examples. One, a patient that I had this last month who is a 30-year-old who's a survivor of an early stage breast cancer. And she had had a headache, and another doctor had ordered an MRI, and it had an abnormality in her brain, in the covering of her brain. And when I saw this, because I ask all patients to send every scan they ever have to me, I said, "Oh, you need to come in. We need to talk about this." I sent her to the neuro-oncologist thinking, gosh, it's possible this could be breast cancer. She got a lumbar puncture. It was negative. And I had her come into clinic to talk to me about what to do next. And she'd followed up with the neuro-oncologist, and they said, you know what, this is inconclusive. It doesn't really show anything, but this is really an abnormal finding. You should probably have a brain biopsy. This 30-year-old woman who's trying to get pregnant. And I said, oh, this is, that's a severe thing to have to do. I said, is there anything else from your medical history at all? And she said, Dr. Patt, about 10 years ago, I had a very severe case of cat scratch disease. I was like, okay. And I was like, I could remember back in the depths of medical school that cat scratched, and I am a trained internist. So in internal medicine, that's Bartonella henselae. That's like the bacteria that causes cat scratch disease. I said, I think cat scratch disease can do some weird stuff, but I couldn't remember, right, what exactly all it could do. Probably I knew that at some point, but not today. And so I opened up my computer, which I always have next to me in clinic, and I looked on open evidence. And I said, what are some of the central nervous system effects of cat scratch disease, and can they be chronic? And so it gave me a list of all of the effects of cat scratch disease and their chronicity, and it gave me links to the peer-reviewed literature. And I opened up some of those articles, and I talked about them with my patient. And I said, I think that this is probably unrelated to your headache, and it's probably always been there. And we can probably spare you a brain biopsy and follow this over time, because likely this is not your breast cancer. The type of breast cancer she had just doesn't usually go to the brain. If she had an early stage breast cancer, it's just unlikely to be breast cancer. And so that tool, the large language model that Open Evidence provides for me for free, made me a better clinician and spared my patient unnecessary testing. In a similar vein, I had a patient come to see me that had major depression before her breast cancer, still has major depression after her breast cancer. She has a high-risk breast cancer. Now she has major depression and anxiety about her breast cancer. Her psychiatrist is recommending that she undergo ketamine therapy for her major depression. And she said, Dr. Patt, does ketamine increase the risk of my breast cancer in any way? Because if so, I'm not going to do it, because my breast cancer was high risk. I know it was high risk. Like, I'm not going to do anything to increase my risk. And again, I don't know. I don't have any other patients on ketamine therapy that I know of. So I didn't know the answer to that question. So I pull up open evidence and I said, is there any evidence that ketamine influences the risk of breast cancer recurrence? And so they pulled up the peer-reviewed literature that was there that I could open and review with the patient. And I said, based on what I can see at my fingertips, I can't see any evidence of increased risk for your breast cancer. And I think you can safely take that treatment. And so, she wouldn't have not been able to take that treatment otherwise. And I could have researched it too, but it would have taken me hours and it would have made the follow-up and discussion with her delayed. And so she was able to get faster care at her fingertips because her doctor was using a tool. And I was totally open and disclosed to her that that's what I was doing. I said, there's this AI tool that called Open Evidence that's free. And you too can use it at home and ask all kinds of medical questions. And it will pull up peer-reviewed literature that then you can go to try to answer your questions. And, in both instances, those young women were very grateful, and it allowed them to, spend less time being anxious about their cancer and really avoid unnecessary tests and get necessary therapy to make sure that they could be healthy humans, which at the end of the day is all I want for them, is their breast cancer to be cured and them to go on their journey of life unabated.
Yeah. Those are such amazing stories. To think about, in the first example, they would have had to go through an unnecessary brain biopsy, especially in that moment in life where I think you mentioned that, she was trying to get pregnant. Like that, it's just having that tool to be able to avoid that and kind of get the information you need. It's such a different way to administer care versus having to go sit back and try to find the article somewhere and do a bunch of your own research. And it's also interesting that I think a lot of that was contingent on you, right? A lot of that was contingent on you knowing that there's a tool out there, having familiarity with how to use it, knowing that you can ask that question, right? I think you can take that a step further. I mean, if you, as you kind of think about the integration with an ambient technology, listening to these conversations and being able to kind of queue up the information that's relevant to you in real time, so that it's not necessarily contingent on that provider or that patient asking that question or bringing up the fact that they have castrate disease in the past. Having all that information kind of cached into the brain of the oncologist. We're not far from that, right?
Yeah, and you just don't. And it's no shade on me as a breast cancer specialist. It has nothing to do with my breast cancer knowledge, right? Because my breast cancer knowledge for both of those patients was perfect. But I can't know everything. And so it helps me to be better. But we use models in other places. So another common place where I use it is their risk prediction models for recurrence that I'll often use with patients. Is they ask me some discrete questions about their risk of recurrence. And, again, I've been doing this for 20 years. I can give them a ballpark estimate, just based on my experience. But what I can do also is use a mathematical model to give them more discrete data and then to help inform them when they have choices like, Dr. Patt, you've recommended that I take chemotherapy, or you've recommended that I take endocrine therapy. But if I chose not to do that, to what degree would that influence my risk of recurrence? And I'm able to, answer those questions in a much more granular way. And to those patients, knowledge is power. Because if they said, yeah, I don't want to take chemotherapy and my benefit is only like 6% over 10 years, maybe I'm comfortable with that choice. But if it was 30%, maybe it would be a different choice for that patient. And so I think it allows us to be better clinicians because we can have better informed discussions with the patients we serve.
Yeah. I think the issue that we're seeing today in kind of the current technology landscape is you have all this amazing science out there, right? And the question is how do you get that science to the fingertips in the right context, in the right moment for that specific physician and for that specific patient in a way that's actually digestible, it's actionable, without that kind of interaction or integration into the clinical workflow. A lot of these tools kind of just sit collecting dust kind of in the research lab or, somewhere where, it's really a shame that they're not being applied to that patient's care.
I feel like investments in innovation have given us Ferraris of care delivery. We really do. We have a lot of great tools. They're amazing. but sometimes our Ferraris require highways in order to act appropriately, in order to really see the benefit of the Ferrari. And sometimes those highways are the infrastructure and care delivery, and sometimes it's the digital tools that we have to deliver care for patients. But I think as organizations, we really need to think about what is our highway going to look like, and how are we going to make sure for the patients we serve that that Ferrari can really be taken out for the best spin it possibly can.
Yeah, that's such a good analogy. So sticking on this topic, just one thing that I like to kind of ask you is that at Texas Oncology specifically, we have hundreds of clinicians that are recording their conversations every single day with their patients, and I think inside these conversation holds the keys to really a new understanding of our patients that we haven't had before, right? A lot of times, I think our understanding of healthcare and how it's administered is basically a recollection of what physicians can remember, and what they think is important enough and choose to document. And in these conversations, you have kind of a new level of detail around the patient's life, their preferences, how they're responding to therapy, and even sometimes around the clinician, like about why they're administering certain types of medications and certain therapies, and your interpretation of how that patient is progressing. I'm curious, like, what excites you most about kind of that idea of having this new understanding, and what specifically would you say, would you kind of look to say, hey, like, I want to look at that first and see, if we can use that to, help train physicians, or we can use that to create some sort of model to help us take better care of patients. Like, what about that excites you the most?
So I think the path of dictation is an iterative path to many functionalities that solve the problems that are the biggest pain points today. So I think when you're using ambient dictation, that's like the first mile of that highway. Then you can do things like code leveling and ICD-10 assist and chart summarization and clinical trial eligibility or clinical decision support for next line therapies, and then prior authorization, and then revenue cycle. And those sound like a lot of different things, but they're all actually iterative functionalities on the same fundamental technology that builds upon each other. And you can sort of see them as different lengths on that highway that your Ferrari is trying to drive on, right? And they each improve your staffing and patients sort of getting efficiencies in their journey in really meaningful ways. So I'm most excited about probably that iteration of taking that particular functionality to its next steps. I think that's really meaningful. And then I think where we have a big gap today, like I think our Ferrari is complicated for patients, and there's more opportunity in patient education than there ever has been, because for many people these therapies are expensive. There are some potentially hazardous complications. We'd like to deliver them optimally in the outpatient setting. I think cellular therapy is a great example of that. Sometimes there's many components of therapy. Upfront myeloma therapy today can have 4 drugs. It's a lot of patient education. Our patients come with variable awareness of the therapies that they need to undergo. And we know when they're not educated well, they're not as compliant with the treatment strategy and they don't do as well. And so there's a real opportunity there in patient education. So I think a spinoff that we have to have that is harder for organizations, because organizations essentially aren't paid for patient education. But I think that's a really important investment that organizations need to make around patient education. And I think that they'll find it pays off in every aspect of care delivery, because patients that are better educated, they comply with their therapy, they do better, they're happier. Patients that are educated are less anxious. They'll call the clinic fewer times with questions, I'm guessing. And so I think it's just, those are real investments that make a lot of sense. And historically, we've approached patient education kind of as a one-size-fits-all scenario. Like we give them black and white handouts that are reflective of common toxicities in alignment with the FDA US package insert for different drugs. But that's like reading, a car manual. It's not, that's not easy to read. Most of our patients and their caregivers don't want to consume education that way. We actually have a pilot right now in Texas Oncology where we're doing video education, where the video education for patients is in like these 1-minute snippets, kind of like a TikTok video. I'll never be a TikTok star. I'll just say that right now. But it, provides it in small bits of digestible content, I think, in a way that people want to consume it. And so we need to be very patient focused and get feedback from patients, I think, about how we evolve the patient education piece. But in my mind, that's a real unmet need.
Yeah. I mean, I view it as kind of this like virtuous feedback loop, right? Like, starting with ambient documentation, you have this new understanding of the patient that can be used to feed all these other things across revenue cycle, research, clinical trials, et cetera. And then that kind of flows back into delivering a more personalized kind of care for that specific patient. And then you can kind of use that technology and use kind of how that patient is responding to give them more tailored and personalized patient education. I actually saw one of the videos of Dr. Gupta in one of those 1-minute videos, and I loved it. Like, I can't tell you how many pieces of paper I got back when I go see the doctor that I never read and then just go directly into the trash. And, being able to see somebody's, like Dr. Gupta's face, you're a doctor telling you exactly what you need to do, and having that being like in a digestible content that in words that you would understand, I think is such a new idea that seems so obvious, right? But we're finally starting to have, technology that allows us to do these things at scale.
Yeah. And Manish, Dr. Gupta has been a wonderful leader of a lot of our digital health strategy with Dr. Cheek and Dr. Haroff and Dr. Doshi. So lots of important doctors, I think, to carry that charge. And you need that, you need people that are going to go into this space and say, okay, let's work with our administrative collaborators. Let's frame what this highway is going to look like. Let's map it out together, and create a path that's going to make us better.
So, Dr. Patt, the last question I like to kind of ask everybody, our audience has a lot of people from the technology side that is interested in figuring out how do you build, really best-in-class products for healthcare that people love, but also on the clinical side of, learning more about technology and, how this magic actually works. Really the question is, in your position, what is one thing that you wish, technologists like us, like really just understood more about doctors and how they adopt technology or how they look at technology? And then also vice versa. What is something that you wish doctors would kind of appreciate more about technology that they might otherwise not today?
What I wish technology companies that were innovating in this space knew better, understood better, is the operations and clinical workflow. Come see a clinic. Spend some time with us, see the challenges that we have, understand our workflow, understand our patients. Like, I think that there is a huge gap there in communication and understanding that is a barrier for many people, because I think I've seen a lot of tech solutions that really don't take that into account. And it seems to me that that's a gap that really needs to be closed. I will say I appreciated that early in my life, that sometimes with my collaborators, there was a communication gap. And I remember thinking around business leaders that they were probably never going to go to medical school. So I went to business school to try to be a better communicator. But I think that people do need to spend some time in the clinic to understand meaningful solutions. And I think that what you need to understand about doctors and what doctors need to do differently is sometimes, because time is our most precious resource and it's really limited, that if it seems like something when we first try it is not going to work out or is going to take a little bit of extra time, sometimes we're resistant to continue to try it and iterate and see if we can get better. But people do need to kind of commit to, I'm engaged and I'm gonna do this and improve. And I'll just give you an example. I'm efficient in clinic. I see anywhere from 25 to 30 patients in any clinic day. And most of my patients either have a new cancer or a cancer that's progressed, because I have other talented advanced practice providers that really manage my patients that are in survivorship. And so my clinic is enriched for these high acuity patients. So it's a busy clinic day, but I'm really efficient. So when I started using an ambient scribe, it was a little clunky for me at first because I have a certain process workflow. I had to change my process workflow a little bit. I started bringing my computer and my phone in the room with me and had to sort of think about, okay, I'm going to do this first. Okay, if I'm going to have an ambient scribe say what I'm doing, I have to say, okay, I'm in your breast exam, and I'm like talking to the patient, so the ambient scribe picks it up. But your right breast exam is within normal limits. You have no lymphadenopathy that I palpate. Your left breast exam is within normal limits. So I'm saying the exam as I go along and being more articulate. The other change I will just mention that I had to make is I tend to be kind of chatty about my family and all kinds of other things. And I just had to sort of mentally note to pause it when I'm chatting about like my own stuff that patients ask me about, my daughter in law school, my daughter in college, my son in high school, just to make sure that doesn't get in there. So I had to change my own process workflow a little bit. And it was hard for me. And I think I'm ripe to change. Like I'm really excited about it. So I think that's hard for doctors, and we need someone to help pull us along a little bit to commit to the process.
I love that. I mean, I think, like with all technology, like I said, like it's different for everybody, right? And I think without kind of receiving feedback from you or from any of the users, it's almost impossible for us as vendors to actually like really build technologies for you, right? And so I agree, like, you can't make a first impression, twice, but at the end of the day, like having that partnership is what ultimately is this kind of like iterative loop that moves both parties together. So, I appreciate that insight. Well, Dr. Patt, it's been such a wonderful conversation. I really
Thank you.
appreciate you having us on. I think we covered a lot of really amazing topics from kind of where you started and policy and where the technology can go and where it should go. So again, I just want to thank you for your time. And
well, thank you, Matt. I will say you guys have been great partners in our innovation journey and helping us build that highway together. So really appreciate that, because it's only through good partnership, I think, that we build the right path to move forward to where we want to go. So, I really, it's a two-way street. So thank you.